Walk into any modern senior care facility today, and you'll see teams using sophisticated software to manage almost every aspect of daily life. We've been told this massive digital build-out equals modernization. But when those systems fail to connect, that digital transformation is an illusion. Over the last 20 years, operators have bought software to digitize every individual workflow. You have an electronic health record, or EHR, for clinical documentation. You have a CRM for tracking sales leads. You have entirely separate platforms for scheduling, payroll, and billing. Each piece of software works well on its own, but there is a structural flaw built into this model. Vendors optimize their products to solve specific, isolated tasks. The clinical application speaks clinical language, and the accounting application speaks accounting language. They aren't designed to talk to each other. What you end up with is a series of systems of record. They are great at capturing isolated transactions, like noting a missed medication or clocking a nurse's shift. But capturing a transaction is very different from understanding how that event impacts the broader healthcare enterprise. Simply adopting more software doesn't solve the problem. It creates application sprawl. When every vendor holds a fragmented piece of the business, it creates dangerous operational blind spots across the entire organization. Those blind spots widen the gap between where data originates and where decisions are made. A nurse on the clinical floor sees care data in real time, but the executive team in the boardroom only sees high-level census and labor summaries. This leads to something called cognitive lock-in. The software vendor's narrow product model inadvertently dictates how the operator understands their own business. If a dashboard only tracks one isolated metric, leadership only manages to that one metric. Because the data is siloed, executives are forced to manage by looking in the rearview mirror. They spot patterns only after the damage appears, in trailing indicators, like sudden spikes in staff turnover or drops in net operating income. Relying entirely on isolated vendor dashboards means leadership operates in the dark, reacting to systemic failures long after the financial damage is already done. Let's test this fragmented system against a real-world scenario. Imagine a resident's health condition requires a higher level of daily care. In the industry, this is called an increase in acuity. This animation shows how data flows in a typical siloed environment. First, the clinical system registers the resident's changing needs, and nurses step up to provide more intensive labor. But a digital wall blocks that information from automatically reaching the billing department. The immediate result is an economic leak. Labor costs surge to cover the extra care, while service revenue remains exactly the same. The facility is doing more work for the same pay, which quietly drains the overall operating margin. Now, let's introduce an operating intelligence layer. The wall dissolves. A clinical change in the resident's acuity instantly updates the staffing schedule to ensure proper care, and simultaneously triggers an adjustment in the billing system to capture the correct revenue. You cannot effectively protect your operating margin unless the ground-level clinical realities are mathematically tied directly to your financial systems in real time. This unified approach extends far beyond revenue. It is absolutely vital for preventing the highest-stakes crises in senior care today: severe compliance failures and state survey citations. State citations rarely happen without warning. The precursors are usually hiding in plain sight. Perhaps a cluster of late assessments sitting in the clinical app, combined with a heavy reliance on temporary agency staffing logged over in the payroll system. A unified intelligence layer constantly cross-references these isolated data points. It detects the collision of low staffing and missed documentation, flagging a highly exposed community weeks before an auditor ever walks through the door. This document outlines how top operators are actively applying this framework today. By organizing data around the operator's needs, they establish specific, practical use cases for intervention. Notice the focus on early survey risk detection and labor variance. These are active connections, proving that workforce instability directly correlates to clinical risk. Connecting these data points turns compliance from a panicked scramble into a highly controlled, predictive process. Zooming out from the facility floor, we see how this operating intelligence dictates the broader capital strategy of owners and large investors. Senior care exists as a unique duality. It is an intense, human-centered clinical operating business, but it is also a massive, highly leveraged real estate asset class. Making major capital expenditure decisions without a clear view of both sides is blind gambling. You might renovate a wing to attract new residents, but if you don't know the labor intensity those new residents will bring, your investment might actually damage your bottom line. To solve this, facilities need an enterprise memory. This is a unified historical record combining clinical, labor, and financial data to prove exactly which operational interventions generate durable real estate value over time. Without that complete enterprise memory, investors and owners lack the visibility required to accurately project, protect, or increase the valuation of their real estate assets. The reality is, major software vendors will keep expanding their clinical tools, and they remain essential. Operators shouldn't try risky rip-and-replace strategies, tearing out systems their nurses already know. The true architectural fix is building a neutral Layer 3 intelligence platform. This is a governed data layer that sits securely above all your existing vendor software, collecting and organizing the information into one cohesive picture. This white paper highlights a precedent in life sciences. IQVIA and VVAT were locked in a data conflict until enterprise customers forced interoperability. The lesson? Enterprise customers reject closed system conflict. When rivalries block performance, the market bends toward interoperability. Data must be mutually usable. Software vendors will always own the applications. That is their business. But to survive the complexities of modern senior care, operators must aggressively own the operating intelligence.